A step-on session, resuscitation of critically ill patients. Dr. Nisha Bhojnagarwala will be delivering the lectures. We will just starting, okay? Everybody be there. And kindly mute your, if your surrounding is a bit disturbing. Huh? Okay, we're starting then. So I advise Nisha to start the session.
So, in what situations do we require resuscitation? In a pulseless patient, a patient in severe shock, patient with acute respiratory distress, and unconscious patient. So, we have the few scoring systems which are used to identify a unstable patient, like NEWS2 score, MUSE score. So, NEWS2 is a national early warning score too, and MUSE is a modified early warning scores. So basically, these scoring systems, they uses the few physiological parameters like temperature, respiratory rate, heart rate, saturation, blood pressures. So basically, these parameters when assessed together, they and if they result in a higher scoring systems, it suggests an immediate interventions by a critical care team. So basically, we use these scoring systems in a emergency in the emergency for the assessment of the patient who arrives in emergency in the RR team, rapid response team, while giving the ward round or in the ICU rounds. So we need to understand one thing. Whenever we are assessing the patient, we need to do a sequential approach. That is a ABCD approach. And we do this assessment. And if in any of the step we find there is any kind of a derangement or any kind of abnormality, so there need to be a frequent reassessment. Treat the life-threatening problem before moving to the next step. First step, look, listen, and feel. So, look means look at the patient's chest movement, listen at the patient's breath through the mouth, and feel the air on your cheeks. So, basically, assess for any abnormal breathing. And if the patient is unconscious, unresponsive, assess a guided pulse. So, if the pulse and breath absent, or if there is a agonal breathing means basically a gasping breath, then resuscitate the patient as per ACLS protocol. Attach monitor, insert IV cannula, and do the CPR. And if the pulse is present, then send the rapid blood sample for ABG and chemistry analysis. So this is basically the ACLS protocol for resuscitating the patient in cardiac arrest, which will be discussed in some other sessions. Airway. So basically in airway, what do we see? So basic aim is to assess, to ensure the patency of the airway. So if the patient is awake and is able to verbalize, it suggests that the airway is patent. But if the patient is unconscious, see for any paradoxical movement to the chest and abdomen to suggest there is any kind of a airway obstruction. And in the patient with a very low GCS, generally GCS low than less than 8, they have a very so the tone of the throat muscles is decreased, causing the tongue to fall back, which obstructs the pharynx, leading to the airway obstruction. So if you find any kind of the airway obstruction, the main aim is to clear the airway of any secretions. If needed, you insert the airway as in the patient with a low GCS, and if needed, use the advanced airway like the endotracheal intubation, or in the case of the emergency situation, you might even use a laryngeal mask airway. And there's some kind of airway maneuvers like head tilt and chin lift, which is used to ensure a patent airway. In a patient with a suspected cervical spine trauma, we do not use a head tilt chin lift. We use a jaw thrust to avoid any cervical spine dislocation. Then in the case of the advanced, so this is, I just want to show how the paradoxical breathing looks like. So this is how the paradoxical breathing looks like. So we have seen many of the patient while giving the ICU rounds, or sometimes in the wards we see the patient breathing like this. So it suggests there is some kind of a airway obstruction. I want everyone just to see this video carefully. What does a paradoxical breathing looks like? So when you find any patient breathing like this, just have an idea that there's some kind of an airway obstruction, be it in the tube which is blocked, or the patient with a low GCS who has a secretions in the mouth, or has a low GCS which needs an urgent intubation for the airway protection. This is a head tilt and chin lift. So the image on the left, it shows the head tilt and chin lift, where the head is being flexed by putting the hand on the forehead, and the chin lift by putting the fingers below the chin and lifting it upwards. This is a head tilt and chin lift maneuver. And the image on the right shows a jaw thrust, where the fingers are put behind the angle of the jaw and it is elevated upwards. Now breathing. So after airway, we go to the breathing. So in breathing, we need to see if there's any kind of the signs of the respiratory distress, like sweating, tachypnea, nasal flaring, retraction, working with the accessory muscles of respiration, any kind of paradoxical breathing, or we need to assess the respiratory rate. So if the patient is highly tachypnic, as we might find the patient in the sepsis or maybe pneumonia with a high respiratory rate, then we need to stabilize them using the NIV non-invasive ventilation or high flow nasal cannula, or if needed, mechanical ventilation. And if they are not dealt with immediately, it may result in respiratory arrest due to the muscle fatigue. Then assess for the bilateral chest expansion. If there is a unequal chest expansion, it might suggest a pneumothorax, with the pneumothorax on the side of the diminished chest movement. Look for any kind of tracheal deviation. Trachea will be deviated to the side opposite of the pneumothorax. See for any auscultate for diminished air entry, as in the case of a pneumothorax, or wheeze in the patient with a significant airway obstruction. So rhonchi means this thing, spasm, where many of times we come across a patient breathing like sigh, 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 hoy. So if there is a any kind of pneumothorax, we need to put the chest drain immediately, check the oxygen saturation level, and give supplemental oxygen if needed. So in the breathing, you need to see if there's any kind of a respiratory distress. Then if the patient is tachypnic, see for the symmetry of the chest movement for any tracheal deviation, and see if there is any kind of sounds, breath sounds like rhonchi, which suggests a significant airway obstruction. Then shock. Shock, it is a state of a tissue hypoxia due to an imbalance between a tissue oxygen delivery and demand, due to an impaired oxygen utilization. Now, it can be a hypovolemic shock, which can be due to a volume depletion or the blood loss. It can be a cardiogenic shock due to a poor cardiac function. It can be obstructive shock due to a pulmonary embolism or cardiac tamponade or tension pneumothorax, or distributive shock due to a septic shock or anaphylactic shock. So in circulation, what do we assess? We see, first thing is, we see whether the extremities are cold, clammy due to a peripheral vasoconstriction. Then in the late stages of shock, we can even see the cyanotic and mottled appearance. So the picture on the right hand side shows how the cyanosed and mottled appearance looks like. So we come across this type of picture many times when the patient is in a prolonged shock for a prolonged period of time and on a high dose vasopressor. Then we see this kind of appearance many times in the ICU. Then assess for the capillary refill time. So if it is more than 3 seconds, it suggests the poor peripheral perfusion. Assess the patient's pulse rate in younger patient. In the initial stages is tachycardia. If left untreated, it will be followed by hypotension in the late stages of shock. You should always take the history, whether there's any history of the heart rate controlling drugs, because the patient might be in the shock with a normal heart rate in these cases. Measure the patient's blood pressure. In the early stages of shock, the patient is most of the time patient is normotensive or hypertensive due to a compensatory sympathetic stimulation. Then hypotension is a late feature of shock. Assess ABG for any metabolic acidosis, high lactate level. Would be cautious in interpreting these ABG, because the metabolic acidosis can be present in if there is a concurrent renal dysfunction, or in the case of toxic ingestion like any kind of alcohol ingestion, or maybe drug intoxications like metformin. Assess the urine volume. So basically, shock is shock is evident if there is a cold clammy extremities, if the capillary refill time is prolonged, if the patient is unusually tachycardic, unusually hypertensive or hypotensive, ABG shows a metabolic acidosis with a high lactate level, and if the urine volume is low. So these features shows that the patient is in shock state. Now you need to assess that why the patient is in shock. So whether there is any cardiological event, for that you do any 12-lead ECG to see if there is any kind of acute coronary syndrome, or there is a life-threatening arrhythmias. Then assess the echocardiography to see if there is any regional wall motion abnormality, or if there is any kind of the cardiac tamponade, or if there is a poor left ventricular ejection fraction. Look for any obvious source of bleeding. Arrange if the patient is in trauma, do the EFAS to see if there's any kind of intra-abdominal bleed, or if there is any kind of a cardiac tamponade, or maybe a pneumothorax, or chest X-ray in the trauma patient to rule out if there's any tension pneumothorax. Then for resuscitation of the patient in shock, always use a peripheral IV cannula, wide bore IV cannula, preferably 14 to 18 gauge over the central venous axis. Then fluid resuscitation should not be delayed or restricted in patient with renal or heart failure who is suspected to have a septic or hypovolemic shock. Now, patients suspected of having the anaphylactic shock, example facial and angioedema, urticaria, history of exposure to allergens, should immediately receive the injection epinephrine intramuscularly in anterolateral aspect of thigh. Now, for the patient who presents in an unconscious state and who has a normal airway, breathing, and circulation, for that patient, we need to assess what is the GCS score of that patient. So, for very rapid, very quick scoring system is a AVPU score. So, if the patient's low GCS, if the GCS is low, that patient might need a intubation for the airway protection. Then assess for the pupillary size reaction. If there is a asymmetric findings on the pupillary reaction, that is one side is dilated and other side is normal, it suggests there is some structural causes of the brain, like there is any kind of a bleed, or maybe cerebral edema, maybe there's a unilateral pressure on the brain. Then assess for the brainstem reflexes in the deeply comatose patient to assess if the patient is brain death or not. Then NCCT brain should be done in all the patients suspected of having the structural causes of coma, especially in the patients of trauma. Patient with abrupt onset of history generally have the structural causes like the stroke, or maybe any kind of a trauma, or a cardiac event like ischemic stroke. And a gradual onset of a force generally suggests of a metabolic or toxicological forces like the septic encephalopathy, or maybe in the patient with a hepatic encephalopathy. Arrange for the EEG in patients suspected of seizure disorder. Measure the blood glucose level to rule out hypoglycemia in the patient with a decreased level of consciousness. Then thiamine should be given to all the patient at a risk of nutritional deficiency, because the patient with a chronic alcoholics, malnourished, pediatric surgery patient at a risk of a thiamine deficiency, and thus they are at a risk of having a Wernicke encephalopathy, who presents with a decreased level of consciousness. Then review medication history of the patient for any intoxication, In patients suspected toxic ingestion, get toxicologic screening done, send routine blood investigation, including electrolyte and special investigations like thyroid and cortisol testing to rule out metabolic encephalopathies. Then remove clothing to perform physical examination. Respect patient dignity. Look for any obvious trauma, source of bleeding. Minimize heat loss. Then review ABCD, manage life-threatening problems, take sample history from the patient relatives. They review sample is sign and symptoms. See for any sign and symptoms of the patient who which might suggest where is the problem of pathology for the patient being unstable. Then review the allergy history, patient's medication history, past medical history, when was the last meal consumed to assess if the patient has aspirated or not, then all the events which led to this situation. Assess the cause of the acute deterioration. Review laboratory reports. Now, thank you. So this is how we deal with a patient with a unstable patient. So you all need to be very meticulous. So you all need to, whenever the unstable patients come to you or whenever you assess the patient for first time, always review the patient in this ABCD manner. So for the first step, always assess whether the patient's breathing is normal or not. And if it appears patient is not normal and if the patient has a decreased level of consciousness, unresponsiveness, assess for the pulse first. If the patient is pulseless, straightforward go to the ACLS protocol. And if the pulse is present, then follow the protocol of ABCD. For the A, ensure that the airway is patent for the patient, and if it is not patent, if you find any sense of airway obstruction, then clear off the airway. If needed, use the airway like nasopharyngeal airway or oropharyngeal airway, or use any airway maneuvers. And then for the breathing, see if the patient is having any sense of respiratory distress. If the patient is unusually tachypnic, settle the patient using the NIV or HFNC, or the patient will land up in the respiratory failure. Look if there is any signs of pneumothorax or any signs of airway obstruction in the patient. Manage if there's pneumothorax, give the chest drain immediately. And if there's any signs of airway obstruction, especially if there's a bronchospasm, nebulize the patient. Then see the circulation of the patient, assess if the patient is in the shock state. And if the patient is in the shock state, assess the cause of the shock. Then, if the patient is unconscious, assess the level of the GCS, assess if the patient needs an immediate airway management, assess if there's any structural causes of the brain or it is more likely to be a metabolic causes. See if the patient is having any kind of seizure disorder. See the patient blood glucose level. See if the patient is at a risk of nutritional deficiency. Assess the patient's medication history and get a toxicological screening done in all the patients presenting in an unconscious state. And always assess the patient sample history. Thank you all. May I ask?
Okay, everybody. Now audible? So it was a very
Dr. Nisha, please unmute.
Yes.
so it was a very good lecture given by Dr. Nisha. Basically, ill patient, basically we need to know the acute event which had occurred and the acute management. At least we save the patient from the acute cardiac arrest, and then resuscitate, and then we go on to find what was the reason, what direction. First, we need to revive the patient, and then we have to go to search what caused those events. Okay. So I hope the message is clear to everybody.
Your session is over.
Any questions?
Dr. Preetam,
Yeah, I'm just asking, is there any queries now? Any point you need explanation? Anyone?
please ask a candidate to type their question in chat box.
Okay, that's good to know, not yet.
Can't hear anything now.
No, okay. We are not getting any questions, so I think if the session is clear, we can close it.
Sir, there is one question in chat box.
Okay. Okay, just now we got it. For pregnant women.
So for the pregnant patients, even you need to treat the sorry. For the pregnant patients, even you need to approach the patient as in other patients also. If needed, give the fluid. You need to assess why the patient is in shock, right? And then if the patient had a recent delivery, you need to assess if the patient is having the hemorrhagic shock, is into the hemorrhagic shock, then give the fluid therapy to the patient and ask for the blood transfusion. And if the blood pressure is not holding, then you can start with the vasopressors. Or if the patient has any kind of a embolism, then you need to manage the patient conservatively with the fluids, with the vasopressors. That is how you need to manage the patient. You need to know what is the cause of the shock and then manage the patient accordingly.